Hi, and welcome to another edition of the Trustcast Show. And I am here. I'm excited to have Dr. Rohan Lall, who is a neurosurgeon at M Health Fairview in Minneapolis and the chief medical officer for SynerFuse, a company that he co founded. And he performed the world's first solo E-TLIF procedure and a new surgery that combines spinal fusion with nerve stimulation to treat chronic back pain without long-term opioids. So this is really, if you're successful here, this is really quite a groundbreaking concepts. So you co-invented this surgery that didn't exist before. What was the moment you realized traditional spinal fusion wasn't solving the whole problem?
Yeah, appreciate that. Thanks for having me, Zane. Yeah, as someone who is a spine surgeon, I do it all day, and so I do a lot of brain surgery and spine surgery, and ultimately, I think anyone who is a spine surgeon could tell you that the field has some limits and certainly opportunities to get better. So I think that we're all looking for ways to really advance the field and ultimately to make outcomes better.
And so, when did you know you wanted to cut into people's spines for a living? I mean,
Oh
sure,
yeah.
it didn't go like that. But how did you end up specifically in spine surgery and brain surgery? I mean, it's such a long haul after you become a
Yeah.
doctor to become a neurosurgeon. You know, there must have been something running around in the back of your mind to make that commitment. It's a big one.
Sure, it sure is. Yeah. So medical school, I often say, is almost like a Greek rush system where you choose them and they choose you. And I don't know if you would perceive this based on doctors that but personalities very much have their own specialties. And so, like pathologists are a certain kind of personality type, and radiologists are a certain type of personality type, and psychiatrists and internal medicine and surgeons are sort of another. And so, a lot of times what will happen is that early in medical school you start doing rotations and you start going around, and one of the first things you notice is just what is the group of people you identify with. And so I knew kind of early on in medical school that, hey, I'm one of these surgeons. That's kind of who I am. That's where I feel comfortable. That's where I feel like I can relate. So I knew early on that I wanted to do surgery, and then it really became a question of what type of surgery and what specialty. And I thought about some different ones. Whether cardiothoracic, transplant. Some different specialties. But there was something about brain surgery. Certainly, the first time I saw the brain, saw the nerves, it spoke to me. The pace, the elegance of the anatomy, the elegance of the surgeries. They're long surgeries that you got to have the patience and sort of the mindset to be willing to do that and interested in that. But it jumped out to me, and so it was really not a hard decision at all, and for me at all at the end. It's a long commitment, though. To your point, 4 years of medical school, 7 years of residency, year of fellowship. So it's a long run for sure.
Mhm. So what's the thing? What was the hardest thing about neurosurgery residency that nobody warns you about?
Well, neurosurgery is not only the longest residency that there is time wise, but also probably one of the most grueling ones. These days, we do have what's called duty hour or work hour restrictions, where residents are not supposed to work more than 80 hours a week. Neurosurgery was the only specialty that, when I was in training, that actually got a waiver to be able to go past 80 hours a week, because that's not enough. So technically, it was 88 hours a week. And without getting too deep on that, because obviously, programs have rules and there's regulations and whatnot, I will just tell you, we weren't watching the clock. So if it was a little more than that, no one was really paying attention. And so the hours and just the immersion of it was crazy. I don't know if you would know this, but actually the term resident, derived from way back in the day, 1960s and 70s, where the chronic, where the new modern kind of medical training developed. And what it meant was it was the person who lived in the hospital. like the resident of the hospital. It was like, you want to learn how to be a doctor? Cool. For a year or two, you get to actually live there, and then you really learn. And so I would say compared to most fields, neurosurgery still very much keeps that attitude about things. And so that makes
Yes.
it very grueling.
Yeah. So why do you surmise, or why do so many back surgeries fail?
Yeah,
I
yeah.
know I had an issue with my back some years ago, and I went to see a neurosurgeon, and he looked at my back and he says, I think it's not too bad. He says, I really recommend against getting a surgery. You just need to wait this thing out and see how everything works out over the next 6 months or so, and let's just watch it. Which was
And that doctor told you that, I probably correctly saying, because frankly, the outcomes of spine surgery overall are not as good as or as regular as the outcomes of many other types of surgeries. If you compare it to knee replacements, hip replacements, the likelihood of people being in chronic pain, addicted to opioids, having inconsistent pain relief, having complications is much, much higher in back surgery. And practically speaking, what that means for a lot of us spine surgeons is, in order for someone to really qualify for back surgery, for that to make sense, I mean, they need to be borderline disabled, or just frankly desperate. Otherwise, you wouldn't necessarily take the risk. That's very common, and that's really part of what we're trying to get better. As to the why, I think that there's a lot of parts of this. One would be that if you think about the knee, it's a single joint, right? And so,
Mhm.
there's a lot of ligaments and bones that insert upon it, but fundamentally it's one joint that needs to move in certain axes. If you think about the spine, it needs to move in many, many, many axes, and there's so many segments of the spine, and that ultimately it's like you have many knees right next to each other. And so a lot of times what'll happen is someone will have arthritis in many segments of the spine, and you have to sort of pick and choose, well, which one are we going to surgically alter? What do we do about the ones that are a little bad but not that bad? How big do we want to make this surgery? And then there's the main part, which is the problem of spine surgery, which is the nerves and the spinal cord. Okay, so nerves and the spinal cord is a very finicky, high stress tissue, very high wired electrical tissue. It does not tolerate chronic injury or scarring well. And when it is getting chronically injured, whether it's by arthritic tissues, instability, or whatever is pushing on nerves, or even prior surgery and scar tissue from a prior surgery, what that does is it chronically injures the nerve, and then the nerve doesn't function normally. And so I think that's what's really different about spine surgery than other orthopedic surgeries.
So I want to talk about your invention and the surgery behind it. And so how did that come about? I mean, so it's called the E-TLIF. What that stands for something, right?
Yeah, sure. So TLIF is the most common posterior spinal fusion surgery. So transforaminal lumbar interbody fusion. So transforaminal is a way of placing the fusion device, the spacer, into the disc. So
Mm-hmm.
transforamen, lumbar, is obviously the lumbar, and then interbody is a type of fusion where you're removing the disc and placing a spacer in there, and that's the most common type of posterior spinal fusion today because it has the highest fusion rates. So TLIF is very, very common. If you have a friend having a back fusion, they might be having it from the front or the side, but if they're having it from the back, they're very, very likely having a TLIF. What we wanted to do was say, how do we make the TLIF a better surgery? And so what we wanted to do was see if there was a way that we could incorporate into that surgery electrical stimulation of the nerves, and see if that could improve nerve pain outcomes after these types of surgeries. And so, similar to, the iPhone, or many devices out there, we thought that, this is an electrified TLIF, an E-TLIF. And so that's really where we came from on that one.
So now I want to get into the nuts and bolts, so to speak,
Absolutely.
of, of how this works. So you say electrified, but what does it hook up to, and how is it powered, and exactly how does that all interact with the body, and what does it? I want to find out more about what
Absolutely.
it does.
Yeah. So when we do conventional spine surgery, when we do a T-lift, what we do is we remove quite a lot of bone and ligament to free the nerves. And then we put in hardware to secure the vertebra to each other to encourage them to fuse together. When we do conventional surgery, we spend all this time as a surgeon removing all these tissue, dissecting and completely freeing these nerves. And a lot of times you'll have this moment at the end of a surgery where you have all these beautiful nerves exposed and they're all free and looking nice, and you say like, cool, look at this beautiful anatomy, look at these nerves, and then you say, okay, it sounds good, let's close them up. What we wanted to do was take this literally once in a lifetime opportunity where you have the nerves exposed and say, how do we help those nerves? And so, excuse me. There is another type of spine surgery and interventional pain procedure that is called neuromodulation. And what
Hmm.
that is spinal cord stimulation, where you place a big paddle onto the spinal cord to deliver electrical impulses into the spinal cord, or else what direct nerve or dorsal root ganglion stimulation, where you place leads onto smaller nerves that have already been exposed and freed. So we had this terrific idea, and certainly, I can't take overwhelming credit for it. Now, in many ways, the most credit should go to my partner on this, and the lead investigator of our trial, Dr. Michael Park, a professor of neurosurgery at the University of Minnesota, also a neurosurgeon who were in the same system, and we worked together. But Dr. Park, more than almost anyone, really had this tremendous idea of saying that what if we use the opportunity of the original spine surgery and placed electrical leads onto these nerves that have been chronically injured? And then we secure those leads to the spinal hardware that we place so the leads don't move. And then we attach those leads to a little battery. And then happens is now the patient can, with an app or with their phone, basically change the settings of how much electricity is being delivered onto these nerves and massage these nerves with an electrical current to basically improve their pain levels after surgery.
So does this is really fascinating. So does the battery reside within the patient, or is it an exterior battery with leads coming out of the patient?
No, it's an internal implanted battery, and so it sits just underneath the skin. For our original clinical trial, we used a little bit larger battery because that was the sort of the thing on the market and the best FDA approved already and sort of ready to go. But we have now developed our own much smaller battery, just very small, and so that'll sit right underneath the skin in the low back off to the side, actually.
And so, how long does this battery last? I'm gonna have all the kinds of like technical questions because I'm really
No, yeah,
curious.
it's fun. Yeah. So most spinal cord stimulation or neuromodulation batteries are designed to last about 5 to 10 years. Now, what's interesting is if you think about a spinal cord stimulator, it is a large paddle that needs to deliver electricity into the entire spinal cord across this membrane called the dura, across the spinal fluid, and so it needs quite a lot of current to be able to stimulate the spinal cord. Normal direct nerve root or dorsal root ganglion stimulators have to stimulate through a thick ligamentous tissue called the ligamentum flavum. So they also require a lot of current to be able to stimulate the nerve. What we found was because we are laying the lead directly onto the nerve, we have been able to stimulate at what's called ultra low frequency. And so we were stimulating at literally 3 to 5% of the what we originally thought prior going into the study. We thought it would be about a milliamp, and it ended up being like a small fraction of that. And so we'll have to see in our next clinical trial exactly how long they last, but I will say that based on our back of the napkin math, when we originally looked at it, we were like, well, how long do we think this will last based on the current settings? And we were like, wait, 110 years, so that would be pretty good. know. We're excited about that part of it. But these are answers. We'll have a much clearer answer to when we do the larger clinical trial.
And so, is the larger clinical trial going to be right there at your hospital? I would think, right? So you can,
It's actually
or
a
is it
national study.
multiple?
So
Oh, it's a
yeah,
national
yeah.
study.
So it'll be 15 or 20 hospitals around the country.
So how did you manage to get 15 or 20 hospitals? This has got to be a chronic
Actually,
problem.
Zane, they all want it. I mean, it's not like
It's got to be a
we've
chronic.
had no lack of surgeons reaching out to us trying to get in on the trial.
Wow.
This is
So
huge, Zane. I mean, there's a million, more than a million spine surgeries a year, of which 600,000 or 700,000 are back fusions. And if I'm telling you, there's 600,000 or 700,000 surgeries out there that have a very, very substantial need for improvement. Technically, there's going to be a lot of people who are very interested in that.
how difficult is the surgery? How much different is it than a typical spine fusion? How much in-service training does a I mean, you already, as a neurosurgeon, you've already went through so much training. You just it's crazy. But how much additional training do you need to do to get somebody up to speed on the device?
The bulk of the work is the thing that the surgeon is doing already. And so, the surgeon is already doing that dissection to free the nerve. That was the hard part. Once the nerve is free, then you just have to basically secure, place the lead in the correct spot and secure it to the rod. So, there is a little bit of a understanding curve that the surgeon has to get, just as to knowing exactly where to put it and what the x-ray should look like. But technically, compared to other technical tasks an orthopedic a spine surgeon or a neurosurgeon performs, it's really not as difficult. The hard part they're already doing in the surgery. The other thing I would say is that some of those technical finesse things as to securing the lead the right way to the hardware and those kinds of things, we are trying to really, really improve through on our end through good design. So we're trying to develop great anchors and develop the battery the right way and make it so that it is very seamless for the surgeon.
So when you're describing, so if you were to describe this to me as a layperson, I mean, I have kind of a medical background, but I'm still very much a layperson. So
Yeah.
the attachment is going on the rod that has been put in for in the fusion spot, and
Exactly.
then that's going on. So how is is it something that makes the how is it positioned exactly, kind of on the inside or to the side, so it's not sticking out it doesn't make a bump on the back, so to speak?
Yeah.
How does that the physical part of that?
Yeah, no, exactly. So, no, it's great. So, in a conventional fusion, right, when you cut out the disc between the vertebra in the front, you then put a spacer there. Then you put in two screws down each pedicle of the vertebra. So let's say you're doing fusing L4 and L5 together. You'd put two screws into L4, two screws into L5, and then a connecting rod on each side. So you'd have two small rods that both connect those vertebra. And so now those rods are connecting the vertebra, and there's a spacer in the front. And in the middle is where all the nerves are. So the stimulator leads are down on the nerves, and then they're coming out towards those rods. In the original clinical trial, what we did was we first tied a stitch down just onto the rod. And then as the lead came over, we'd have someone hold the lead right over that stitch. And then we'd tie another knot down to the first knot, right? So now the lead is tied to the rod via two knots. What we're doing, probably, what we have created for the next version is basically a silicone sleeve that slides onto the rod and then sits there. And then basically just now, all you have to do is slide the lead into that silicone sleeve, and then you just suture that. and the
Hmm.
suture is dissolving. So what's nice there is that, if for whatever reason in the future at some point someone needed to remove those leads, the suture will have already absorbed, and now the lead just slides out easily.
Hmm. So let's talk about efficacy. What have been the results of your trial so far?
We are extremely excited. So, at this point, though, the initial FDA quality and safety study was really designed to prove safety, and so that was 15 patients who have been implanted. And the good news is we had, really no major complications, and the FDA has been very thrilled with that.
Hmm.
Um, Now, we are able to look on our end at data and at outcomes, and yeah, what I would tell you is that on that initial study, the outcomes were awesome. Substantially better than really anything that's been published. But really, it's the next trial, the pivotal trial, which will be randomized, controlled, and will be scaled with a couple hundred patients, and that's where we will be able to directly compare it to conventional fusion. But all of the outcomes you would want to see, opioid usage essentially gone in virtually all the patients. A quality of life, activity levels, pain levels, everything just really exciting in terms of the outcomes.
So when you're doing a double blind study,
Yeah,
so is there people in the study? There's some people who will get the device, and some people will just get like a regular fusion,
that's
and
true. Yeah.
then you're that's got to be frustrating. Just
Well,
I
I
mean,
hear you. Yeah,
from
yeah,
a
no.
scientific basis, but it's
Yeah.
especially when you see something working, it's got to be frustrating to just go through that. But I mean, you have to have it, obviously. But
Yeah, it is frustrating. And, we're one thing we're hopeful for, and we'll just have to see, is there have been times when you're doing a clinical trial and you get about a quarter of the way or a third of the way in, and the outcomes are just so overwhelming that the FDA sort of steps in and says, okay, let's give everyone the better one. So
hmm.
you never know what's going to happen in terms of things like that. But yeah, I mean that's science. I mean you got to prove
Yeah,
it, and you got to and there is nothing as powerful as randomized control. And so
right,
that's
absolutely,
you know
absolutely.
yeah.
So basically, if I understand this right, you really took two technologies or ideas that already existed, which is the stimulation of the nerves and the fusion, and you just married the two ideas together into one procedure. Did I
That is that
oversimplify
that
that?
is no, you didn't. That is true. We combined neuromodulation and fusion in a way that hadn't been done before. That is true. And dorsal ganglion stimulation and direct nerve stimulation, that has existed. So yeah, that's not a new procedure. What I would say is that what happens today very often is when someone has a failed back surgery, a failed back fusion, um, what happens is they go years before they get to neuromodulation. So
Hmm.
most of those patients often do end up getting a spinal cord stimulator. But what's been looked at is that, and then once they get the spinal cord stimulator, they tend to get about 50 or 60% additional relief. But what we see is that the median time to where they finally get the spinal cord stimulator is about 5 years. So I mean, 5 years of suffering until you can get more relief is kind of brutal, right? But it's just hard because you have the recovery from the original surgery, and a lot of times that takes a long time, even in someone who's going to be successful. So to really parse out who's going to be okay sort of in the delayed way versus who's going to continue to have a lot of pain, it takes a long time. And then after that, a lot of times patients have to do still so much therapy and injections, and kind of jump through all these hoops and insurance requirements and whatnot, that it ends up being a very long time until they can get relief.
So the manufacturing side of things. So have you
Yeah.
partnered up with you've obviously partnered up with somebody to get to this place, a manufacturer who's helping you design and put this into place. How is that all going?
It's going very well. We're working with a manufacturer called Valentium, and yeah, we're very excited about the physical product, the hardware that we've developed here. We think that's a huge part of this. Custom nerve stimulators, a really terrific battery with all the bells and whistles and Bluetooth and physical monitoring, tracking, keeping, a lot of different stuff. So it's that's a huge part of it is the hardware. But we've got a great partner.
So how long between now you've got this great idea,
Yeah.
Ronan, and you're on the way. How long before something like this is available to anyone with a back issue?
Yeah, so the next step is the pivotal trial, which we are actively planning right now and hoping to get started if not by the end of the year, then early next year, and then the pivotal trial will probably take a year or two, and then we're looking at going commercial after that.
Yeah, that's exciting. Okay, well, let's just so if somebody wants to get in touch with you to talk about this, or another physician who wants to find out more about being part of your trial, how would they go about doing that?
Yeah, so we are at SynerFuse.com is our company website, and all myself and the rest of the team are on there, and with contact information and all. And yeah, we're already hearing from a lot of doctors and a lot of patients, and we want to hear from anybody who's interested, about how this can help them and whether this makes sense for them, and just about the company and our mission. So yeah, absolutely.
So, I mean, usually a product like this is the start of something much bigger. Do you have other things rattling around in the back of your
We
head?
do, we do. We have a really great IP patent team as well, and frankly, we've got many patents and directions we want to go in this space. All of this was in my mind just trying to sit and look at it from 30,000 feet at what do we think the spine surgery of the future needs to look like, and how do we just make this better, and so this is a huge piece of it, but frankly, there's a lot of other things, such as, for example, right now, this product and our clinical trials are focused on the back, but we need to look at the neck also, so that's going to be a big one for us. And then, how do we use electricity to improve the rate of spinal fusion, prevent other complications? So this is really just a piece of the puzzle for us.
Yeah. So very exciting. So I think we'll just wind it up right there. We covered most of the major points. That was really good. I really appreciate that. I found it interesting. I think our
Yeah.
our viewers will find it interesting too. So this will go up on. So let me press the stop button. And
Yeah.
we'll wind it up right here. I really appreciate it. But hang on for a second.